Dr. Felice has another speaking engagement in Tri-Cities, so he has to leave promptly at 1. So thank you all for coming today. This is a new room. I hope you like this room better than the auditorium. Someone just called me and they were over there, and I had to direct them to come to this room. So I think if we like this room, we'll continue to maybe meet here. I don't know. Depends on what you guys want. So I'm Judy Yoon. For those of you that don't know me, I was diagnosed with cervical dystonia December of last year. And you look at me and maybe don't, doesn't seem like you can tell that I have anything. It's an invisible illness, but last year I had quite a bit of movement, with videos capturing a lot of my movements. So losing control of balance, I couldn't walk. So that was actually when I sought out Dr. Felice last year to try, to combat some of the symptoms of chronic pain. So anyways, a little bit about Dr. Felice and our guest speaker. So Dr. Felice, he did his undergraduate study at Penn State University. Played a little bit of lacrosse, so he's a little bit of a fitness person, and majored in psychology. So his focus was on, I'm reading here, his peak human performance, and then he came to Washington State to study naturopath medicine. So he went to Bastyr, and he's also recognized as a cannabis expert. So also on the Cannabis Defense Coalition Board here in Washington State as an advisory. So he also lived abroad for 6 years in Asia, where he studied Zen Shiatsu, I don't know if I pronounced that right, and Tai Chi, and he also earned a 3rd-degree black belt in Aikido. So he's quite diverse in his interests and his background. But I think, what I'm very, very happy that he's here today is that he kind of has this philosophy where he believes that the renewal of health, and I'm reading this from just, his website, on a deep level requires a shift in behavior and a change in awareness. He strongly believes that a large part of health is about personal transformation. So he's done thousands of hours of manual therapies, which include manual medicine, cranial sacral, visceral manipulation, and of course medical cannabis evaluation. So that's what we're going to talk about today, is understanding medical marijuana. So Dr. Felice, welcome and thank you.
Thank you everybody for having me. I first came to, and my name is Dr. Jake Felice. You can get the presentation on either of my websites, drjakefelice.com and or cannabismatrix.com. Thanks to Judy, to Ian, to Rod, to all of you who I haven't mentioned for just helping out put this together. I do have to run very sharply at 1 o'clock, and I want to have extensive time for question and answer. So I'm not going to get all the way through the PowerPoint. But think about your questions. If you have questions as we're going through, write them down. I'm going to try to leave about 30 minutes at the end. What brought me to medical cannabis as a clinician was for my patients who were reporting results to me. Got me very interested. This was about 4.5 years ago, and I started doing my research. The thing that is very interesting about medical marijuana is that there is definitely what I see a media bias in medical marijuana. Has anyone seen any of the CNN specials? Usually when you see a media piece on medical marijuana, it's somebody smoking a joint or lighting a pipe or something like that. That's what I recommend my patients don't do. I don't recommend that they smoke it. There are carcinogenic compounds in marijuana smoke, but there are other delivery methods that have benefits. We'll talk about that a little bit today. The other thing to be aware of with marijuana is that it is a botanical, meaning it's a plant, and that plants, by their very nature, behave differently than single molecule drugs. If you buy Tylenol on the shelf here in Seattle, it's the exact same thing you will get if you go to Sarasota, Florida, which might be a better place to be today with all this rain that we're having. Marijuana is different. There are more kinds of marijuana than there are types of dogs. You'll also hear in the media narrative that we need more science concerning medical marijuana. And I absolutely agree that that's true. But what I think is also not stated is that there is actually more science on marijuana than any other plant in the entire planet, the entire biosphere with the exception of one plant, meaning there is a lot of science on marijuana. Any guesses on what that one plant that has more studies than marijuana might be?
Tea? Tobacco?
Tea? Tobacco? No? Good guesses. I was surprised too. It's actually garlic. Can you believe that? So there are actually vast amounts of studies on marijuana, but we need more, and we need more human trials. Here is a list of partial health conditions, and you'll see there are different colors here, and also that some of the green is bolded. We have now evidence for clinical efficacy in humans for all of these. The black are lower degrees of medicine. Green is higher, and bolded in green we have the most. And I think I would have to change the diabetes piece because there's now some new and exciting information on diabetes. The FDA, and this is, if you learn one thing today, this is what I would hope that you would learn. And also, by the way, all of the PowerPoints have the peer-reviewed references. So I'm not going to spend time on those, but this is from an FDA white paper, Guidelines for Botanical Drugs. The FDA actually considers botanical drugs to be in a separate class than single molecule drugs. And this is from their white paper. Because of the unique nature of botanicals, and it's largely because of their low toxicity, the FDA finds it appropriate to apply regulatory policies that differ from those applied to synthetic, semi-synthetic, or otherwise highly purified chemical drugs. And this is what's really interesting because we hear a lot about studies. Such products may require fewer non-clinical safety studies under this section than would be expected for synthetic drugs for which there is little experience. What we have with marijuana is unique because we have a lot of human experience with marijuana. One thing that is interesting about marijuana is in any medical peer-reviewed journal, in any language, ever, there's not a single case report of a death by overdose from marijuana. There are problems with marijuana, but a toxic effect causing death is not one of them. In the United States, largely due to the aging of our population, there has been a tripling of opiate prescription overdoses since 1990. You can see the rapid increase. For a lot of folks, opiates and NSAIDs are the mainstay of chronic pain. And this comes from the Journal of the American Medical Association, a very respected peer-reviewed journal. In states where we have medical marijuana laws, there are 25% fewer opioid overdose deaths than in states that don't have medical cannabis laws. And I'm going to look, or we're going to look a little bit into why that might be here in a little bit.
So that's only one state, right?
This is in all of the states in which there are medical marijuana.
There's only 3 states, though, right?
No, there are now over 20 states with medical marijuana laws. There are 4 states with recreational laws. States allowing medical use of cannabis have lower rates of death from opioid analgesic overdoses. They also have fewer veteran suicides. Suicide rates for veterans are much lower in licensed states. NSAID toxicity. I am an aging, think of myself as an aging athlete. I surf now, that's my current passion. I use NSAIDs sometimes, but I use them understanding the risk involved. And this is from the New England Journal of Medicine, which is also a very well-respected journal, 16,500 NSAID-related deaths yearly, with just 2 disease conditions, rheumatoid arthritis and osteoarthritis. So if we just look at 2 disease states in one drug class, that actually would be the 15th leading cause of death in the United States. And the FDA has just strengthened its warnings on NSAID drugs, mostly for chronic use, not for acute use, because they raise risk of heart attack and stroke. And so folks who are at risk for those conditions should be aware that medical marijuana may be option, and we're going to look at some of the science in terms of folks making choices with that. One of the things we do know about marijuana are its toxicity levels. The LD50 is, the LD stands for lethal dose, and 50 stands for 50%. 50% of people who smoke, or the LD50 is the dosage that causes death in half of humans. Smoked cannabis requires that 15 pounds of cannabis be smoked in 15 minutes to induce a lethal effect. And it's not from the marijuana, it's from the carbon monoxide. There's another very important thing with drugs called a therapeutic ratio. The first number, and you can see here that for commonly prescribed drugs is 1 to 10, for aspirin is 1 to 20. The first number is the therapeutic dose, the dose that is effective. And the second number is the toxic number. The therapeutic ratio for cannabis is between 1 in 20,000 to 1 in 40,000. So about a magnitude of 10,000 times safer than common prescription drugs. For edibles, the LD50 of some legal and illegal drugs are lower here. We use the term milligrams per kilogram, and the kilogram is the weight of the person, or the animal in this case, and the milligrams is the dose. 120 for caffeine, milligrams per kilogram, actually is a lethal dose. Nicotine, which is more toxic, 50 milligrams per kilogram. Heroin, depending on what you read, between 10 and 350, and that's because its strength varies so much, the street drug. And this is a true statistic. Cannabis over 20 million milligrams per kilogram. That's because it requires over 150 pounds of cannabis edible to cause a toxic dose. So that's one of the reasons why we don't see, there are other problems with cannabis, and we will chat about those in a bit. So just in terms of medical decision making, there's something called a risk-benefit ratio. What is the risk to the patient from a certain medication or treatment? What are the potential benefits? One of the things that I enjoy clinically about utilizing marijuana is that I feel very safe that the patients are not going to die from the medication. That's actually a real strong risk factor. The main things that patients have problem with marijuana is either it's not effective, or the side effects, usually of the head high, are common issues that folks have. But we don't see end organ damage. In fact, what we see, very interesting with NSAID use, which we had talked about previously, is that smoked marijuana actually protects the stomach lining from NSAID irritations. So there's this idea of using, in plant medicine, of using synergy. When I mean synergy, I usually mean that the whole is greater than the sum of the parts. The classic example of synergy is in alloys in metals. We live here near Boeing. You cannot make an airplane with steel. It's too heavy, and the jet engine gets too hot and it melts the steel. But if you add chromium and nickel, you get an alloy which is much lighter, it's stronger, it's more flexible, and it holds up under higher temperatures. One of the things with plant medicine that I think a lot of my colleagues on the conventional side don't understand is that we're dealing with very low toxicities and very high potential for benefit. But because there are more types of marijuana than there are types of dogs, for example, it can be a challenge to do clinical studies. And I think the reason that a lot of clinical studies are not, one of the deficiencies in a lot of clinical studies is that the people designing them really don't know very much about marijuana and the different types. There's something that we call harm reduction, where we substitute one substance for something of lesser toxicity, and this is intelligent medicine. And medical cannabis patients have been engaging in substitution by using cannabis as an alternative, not only to prescription drugs, but also to alcohol and illegal drugs. There was a drunk driving study in California, and what they found was, and they used huge numbers of patients, 9% fewer motor vehicle fatalities in patients who were using medical marijuana. And the reason wasn't because marijuana makes you a safer driver, it's because the marijuana patients were using less alcohol, and that made them less bad drivers. Cannabis was a part of the U.S. pharmacopoeia up until 1941. These are old tinctures that you could buy in any pharmacy, and they were under wide use. Its first medical use was reported over 5,000 years ago, and it has been used historically for putative. The word putative means generally accepted as true. This color is black, something that is considered true, obvious, and is antispasmodic, which can be very helpful in dystonia. Analgesic, which means pain relieving. Sedative, it's very good for sleep, and anticonvulsive effects. These are the putative pieces. Now, whether or not, or how good it is for Crohn's disease or other things, we need more studies on those. But for these particular reasons, marijuana is considered putative. Humans have been using cannabis for a long time. This is from the Journal of Experimental Botany, where they actually looked at a tomb of a person who was buried with, amongst other things, a bow and arrow, a harp, and a large satchel of cannabis. And this was in Central Asia 2,000 years ago, and what they found was that this strain really very much resembled chemotherapy strains, interestingly, and they hypothesized that they were using it either medically or for visionary purposes, meaning to get high. But when you look at it, and after the talk, you'll realize that for whatever reason, this is a strain that got folks high. And what I find very interesting is that this person who was buried in the middle of China 2,000 years ago, we can tell from chromosomal studies, had blue eyes. Very interesting that somebody was that far from home with a huge bag of marijuana at that time. In 1937, the American Medical Association said, don't make marijuana illegal. It's, first of all, we don't have any evidence it's showing harm, and that the act of prohibition would inhibit further studies. Nonetheless, it was completely removed from the U.S. pharmacopoeia in 1942. In 1970, cannabis was declared a Schedule I drug under the Nixon administration, and since then, cannabis studies on humans in the U.S. have been nearly impossible to conduct. We have to go through huge regulatory loopholes to study them. A lot of the good studies now are coming from Israel, and we'll see some of those in a bit. Synergy is important, and we're going to go into some of the science of why that's the case, and remembering that these are very low toxic compounds. So there are 4 ways that you can use synergy with plant medicine. One is with looking at the molecules that are in the same plant. So say, for example, who here has heard of the word THC? Good. Most people have. What about CBD? Has anyone heard of that? Okay, about half of you. Okay. When I first started with patients about 3 years ago, none of them had heard of CBD, so I think that the media is doing a good job at educating us. In plant medicine, one of the major benefits is that we can utilize secondary chemicals, such as CBD, to increase the positive aspects of the primary active constituents. So in the case of THC for pain, for example, THC plus CBD gives better pain relief, 2 to 4 times the amount of pain relief than just high THC marijuana or just high CBD marijuana. So the combination increases the benefit. Also, the combination can decrease the negative side effects of the primary active ingredient. So patients on high CBD medicine, even though there is THC, have less anxiety, they have less paranoia, less of a risk for psychosis, less of a risk for overeating, which can be a factor for some folks, but a benefit for others, and also less short-term memory loss. If you focus on secondary chemicals, just focus on the CBD and the THC. We don't have that much time for that. The second way that we can use synergy, however, is utilizing different delivery methods. For example, like cannabis topical, which is a lotion or a cream that you can apply externally to muscles, such as the SCM, the sternocleidomastoid muscle. We know that the THC actually does penetrate all the way into the muscle tissue. And that when we combine a topical with either an edible or another method, you get a combination effect. That's because marijuana relieves pain not only in the central nervous system of the brain, like Tylenol does, but also in the spinal cord and in the periphery. So when we utilize a topical, that is helping in the periphery, and when we use an edible, that is helping more centrally. So we can use synergy to synergy of delivery methods to magnify that. The third way that we can use marijuana is synergy with other medications, specifically opiate and NSAID medications. And this is good news for folks in chronic pain, and I'm going to show you the data on that in a little bit. Cannabis studies show that whole plant extracts demonstrate 2 to 4 times greater the effects than THC alone. So it is the combination of THC plus CBD that gives the best pain relief. Again, some folks don't like THC. It makes you high, and some people don't like that. But what's interesting in the science is that it's showing that levels that are lower than the psychoactive dose actually do have benefit. I'm just going to slide through these. You can read about them, but here CBD antagonizes undesirable effects of THC, such as intoxication, memory loss, sedation, and anxiety. The journal articles are here for your future reference. At the same time, CBD enhances desirable effects. So the good gets better, and the bad gets not as bad with this combination. Also, opposite mental and emotional effects of THC and CBD. THC can increase anxiety as well as levels of intoxication and sedation. And there is a trend for reduction in those problems following the administration of CBD. So for pain, I like to have all of my patients utilizing a high CBD strain, which we can now get in Washington because we have laboratory testing. But for the street drug, only about 1 in 50 strains of marijuana have CBD in them. Why? Because you don't get as high with CBD. So it has been selectively bred out of the plant for recreational and other purposes. Pre-treatment with CBD prevents induction of psychotic symptoms from THC. So yes, I have had patients have very frank, disturbing episodes of psychosis with marijuana. Usually high doses of edibles, not from inhalation, but edibles, and pre-treatment with CBD prevents that. That is one of the problems with medical marijuana, is the high THC. Smokers of high CBD THC strains show reduced attentional bias to drug and food stimuli compared with smokers of low CBD THC. Translation, less munchies with high CBD. Who would that benefit? Diabetic patients. Who might it not benefit? Who might that not be a benefit for? Cancer patients who are having appetite suppression from chemotherapy and radiation. So you can see that we utilize different plants for different conditions. Also, if you're designing a study and you want to show if cannabis is effective for pain and you're using strictly a high THC strain, you might get a very different result than if you use a high CBD, high THC strain. This is Scientific American. High CBD strains attenuate memory loss. The memory loss is not a factor nearly as much in folks who are using high CBD strains. There's a lot of information about this. Another study in cancer patients showing that THC-CBD combination shows a more promising efficacy profile. Again, however, if the cancer patients need appetite stimulation, we use a little bit of a different mix. But here's what's really exciting. You can still use your opiate medications with medical marijuana because the brainstem has cell receptors for the cardiorespiratory center in our brainstem does not have marijuana receptors. The rest of the brain does. So you cannot marijuana will not stop your breathing or your heart. In In this study, all patients taking opiate pain relievers report they reduce overall drug use, especially by using medical marijuana. And we also see cannabinoids not only produce analgesia, but actually make the opiates work better, so that if a patient is getting tolerant from the opiates, the marijuana can actually help the opiates work better. This has been found in a number of studies now, and is really exciting. So not only does synergy work with cannabis between the different molecule types and between the different delivery methods, but we can use synergy with other medications such as opiates to actually help them work better for folks in pain. One of the reasons why I think we have fewer overdose deaths in licensed medical cannabis states. Also, if you're trying to back off of the opiates, marijuana can be helpful for withdrawal symptoms, as well as for cocaine and alcohol. The marijuana actually can help reduce the withdrawal symptoms. And these studies are, again, on the PDF that I have posted for you guys. More cannabis synergy with opiates in terms of its effectiveness. Cannabis reduces use of other medications. Benefits include adequate symptom relief, fewer side effects, and for some of you, the lower cost might be a big factor as well, depending on the prescriptions. I recommend topical cannabis for almost all of my pain patients. It doesn't work for everybody, but if it does work for that patient, I consider them very lucky, because it really can do a lot of things. It usually only takes about 2 points off the pain scale. So if the pain is a 7 out of a 10, usually comes down about 2 points. But the topicals also work synergistically with topical opiates, for example. And as I said before, in this study, vaporized marijuana. So have you seen the e-cigarettes? Have you seen those? So they're breathing in the nicotine with no smoke. They have those for marijuana as well. In this case, they use that. Vaporized cannabis augments the analgesic effect of opiates, and this is key, without significantly altering plasma opioid levels. Some medications interact with opioids and keep them in the bloodstream longer. That can cause problems. We don't see this. So this combination can allow for opioid treatment at lower doses with fewer side effects. Symptoms of opiate withdrawal decrease in patients undergoing methadone maintenance who use cannabis. So people trying to come off of the opiates, the marijuana can be helpful as well. Marinol versus natural cannabis. Marinol is a synthetic THC. It's used for nausea and vomiting. It's effective for that. But the synthetic THC patients don't like it. It takes about an hour and a half to work. Marinol does not have some of the other therapeutic compounds available in natural cannabis, such as the CBD, and because of that, it's much more psychoactive and also much more expensive. Why does this all work? There's something called the endocannabinoid system, and the endocannabinoid system is kind of like the internet of the body. Does anyone get familiar with the concept of a cell receptor? One cell sends a molecule to another cell, it lands on the cell membrane and causes changes. We have more marijuana receptors, they're called cannabinoid receptors, than any other receptor system in the entire nervous system. More than opiate receptors, we have more cannabinoid receptors, more than nicotinic receptors, more than acetylcholine receptors. There's a massive amount of information flowing through the system, and yet many of us have never even heard of it. This system evolved in biology over 600 million years ago. The plant, interestingly enough, is only about 200 million years ago, so the cannabinoid receptors were around long before the actual plant was. Very primitive organisms such as sea squirts and every mammal has an endocannabinoid system. These are some of the biochemical pathways that marijuana is known to affect. You'll see the big blue on top is CBD. THC has been divided into a couple of categories, but I'm just going to highlight here anxiolytic pathways, antipsychotic pathways. I'm starting at 9 o'clock and moving counterclockwise. Anti-epileptic, neuroprotective, vasorelaxant, antispasmodic, anti-ischemia. Very interesting, and when we combine plant modalities, they'll have slightly different colors of the wheel depending on the percentages. This is one of the reasons why cannabis can be effective for more than just one condition. They regulate intercellular communication, especially in the immune and nervous systems. Here we talk about the cannabinoid system acts in every physiologic symptoms that we've looked at to date, and they affect biological oscillators. A biological oscillator is something that keeps something within a certain range, like a thermostat. If the room gets too hot, the heat turns off. If the room gets too cold, the heat turns on. So in biology, we have oscillators that keep things in check with our bodies. Cannabinoids affect the intensity with which neurotransmitters are firing, and they affect every single biological isolator or pacemaker cell that we've looked at, including circadian rhythms, which are sleep-wake cycles, EKG, EEG, peristalsis, slow waves. They're very much involved in controlling things in our body. As I said, it is the most common receptor in the brain, yet it is absolutely, virtually absent in the cardiorespiratory centers, which is amazing because it can be totally effective in all of these areas and yet not shut off the breathing or the heart. If we look at embryology, the fertilized egg requires the endocannabinoid system to attach to the wall of the mother's uterus. If we block the endocannabinoid system, the egg can never actually attach to the lining of the uterine wall. Human breast milk contains endocannabinoids, and if we block the endocannabinoid system in mice, the newborn mice stop suckling and die when we block that system. There is this idea that in some patients there is a deficiency in the endocannabinoid system, meaning the biological oscillators are not operating properly, which is why we think cannabis may be effective, which is kind of gives a rationale for how it can be effective from things so varied as PTSD, migraine, irritable bowel syndrome, Parkinson's, anxiety, and even menstrual cycle irregularities. And here are some of the journal reports here. They do flow backwards in the nervous system, which is important for pain. It's the only neurotransmitter we know that flows backwards. This backward flow regulates the sensitivity of nerve cells by acting as a feedback mechanism that prevents excess activity, whether that be pain or seizures. And when we have seizures or even strokes, some cells die when they are excessively stimulated by neurotransmitters such as glutamate. It's called glutamate toxicity. Cannabis can help reduce this. When we have pain or nerve injury, the endocannabinoid levels in our body naturally increase. I think that when we think of pain, we don't have to think of marijuana as an either-or. When used in conjunction with opiates, cannabinoids lead to greater cumulative relief of pain, reducing and reduction of the use of opiates and the side effects. And cannabinoids also prevent the development of tolerance to and withdrawal from opiates, and can even wake up the opiate pain relief after a prior dosage has become ineffective. There are some protective things about marijuana. And how am I doing with time here?
It's 10:30 or 12:35.
Okay, I'm going to finish up here. I'm going to do a few more slides and then open it up to Q&A. When we look at heart attack induced in mouse models, the actual size of the heart attack with high CBD strains is reduced by 66%. There's a 66% reduction in the size of the infarct. And what's really interesting is, because cannabis is a vasodilator, when I read this, I was like, oh, it's helping with blood flow. But what's really interesting is that in this study, the protection, there was practically no effect on collateral blood flow in the heart muscle, but yet it it still decreased the area of cell, or it still decreased the area of cell death, so it is somehow protecting the heart muscle from the damage of the lack of oxygen. And we need more studies. It does reverse liver fibrosis and also has some anti-neoplastic effects that may impact liver health. This is from the journal Gut, a very prestigious journal. And also anti-spasmodic, anti-inflammatory, and antioxidant properties of CBD and THC not only reduce the symptoms of MS, but we think are also slowing the disease progression. There's actually a lot of studies now on MS and marijuana. And let me see, this is a patient of mine. Actually, this is the son of a patient of mine. The dad is the legal guardian. The son has had a seizure disorder for decades. His son has been doing remarkably well on CBD. It wasn't CBD, it was a high CBD strain, 16-to-1 ratio CBD to THC. We weaned him off all other drugs except for a little Depakote and Lamictal. He has gone from 20 to 100 seizures a day to 0 to 10. And he's even gone for 3 days without a seizure for the first time in 20 years. It's hard to dose marijuana with seizure patients who have infrequent seizures because it is difficult to tell if it's working. But with patients who are having frequent seizures, we can get a lot of a benefit. And this particular patient requires a very specific ratio of THC to CBD. A slight change in that ratio does not have the same benefit. So one of the issues that the dad is having is they're constantly running out of the exact type of medicine that they want. More information on this. I will say I wish I had more time to chat with you all, but I do want to open up to final questions or comments. And Judy's got a microphone. Great.
Yeah. So Dr. Felice has about 25 minutes. So if anyone has questions, Allie's gonna have a microphone. Just raise your hand, and then she'll bring the mic to you. Okay.
Hi, I'm Deb, and my question is for those of us with dystonia that have the tremors, the spasms, chronic inflammation, and pain, what ratio do you recommend for CBD to THC?
Okay, good. Tremors, inflammation, muscle spasm, what are the best ratios? The way that we dose marijuana is kind of similar to how we dose gabapentin, Neurontin, in pain patients, and maybe some of you are even taking gabapentin or Neurontin. We come up with a best guess, and then we allow, because gabapentin is a pretty low toxic drug, give the patient a lot of leeway to decide. But what I recommend is anywhere from a 1-to-1 ratio. 1-to-2 or 2-to-1 ratio is usually about where that starts. For patients who are cannabis naive, who have never used marijuana before, I always recommend an initial starting dose of THC at 5 milligrams or less, because if you're doing an edible and you have too much THC your first or second or third time, you could have a very uncomfortable experience and never want to use it again, even if it does have CBD. So I always start with a lower dose than I think is effective, and then gradually have the patient titrate it up. I also request that they keep a journal, or an Excel spreadsheet is ideal, and keep organized notes too, because if you switch a strain from one type of cannabis to another, that's going to change the effect. But I also tell patients you should expect to have results ideally within the first week. It's not something that you have to take a long time with, and I always caution people, you need to be careful and go slowly with especially edible THC. When we eat marijuana, our digestive system takes it to our liver, and our liver performs a chemical change on the THC, it hydroxylates the 11th carbon, and that means that it makes it stronger, which can be good for folks in pain, but it also makes it last longer, which can be bad for folks who've had too much. So you need to be very cautious with an edible. For folks who have an ability to use a vaporizer, you can get much quicker results, and one of the benefits of a vaporizer is if you've had too much, you just need to wait 30 minutes versus if you've had too much of an edible, it could be a long, rough night. So always starting with a maximum of 5 milligrams of THC. Most folks end up in about the 25 milligram range, but some folks will go up into the 200, 250 range, depending. So there's a huge amount of variability, just like with gabapentin. Thank you for your question. Yeah.
Any other questions? Raise your hand and we'll hand the microphone to you. I think I saw a few hands earlier. Carl? I'll hold this for you. Yeah, I wrote down a few questions.
I actually wrote down a few questions. How about being addicted to it?
There are physical addictions to marijuana, and the symptoms are usually mild. Usually, night sweats are common withdrawal symptoms, and also a type of a restless leg syndrome. But it is much less addictive, say, for example, than caffeine withdrawal, or very much less so than nicotine withdrawal. The main area where patients have trouble with is for patients who are getting sleep relief with medical cannabis. Medical cannabis can be very effective for sleep. However, if you take the cannabis away, it usually means some sleepless nights. This does present problems for patients who travel, who will go out of state, for example. That would be, I think, the most severe thing that can affect folks, because when you're not sleeping, that can really affect quality of life. But it is nowhere near the degree of there's no life-threatening withdrawal like there is for alcohol or opiate withdrawal. So it is a factor, and it is an important factor, but it is not something that, other than the patient's discomfort, that concerns me ever.
Well, you just talked about the physiological withdrawal, but is there any craving for that substance and you don't even need it?
Well, certainly there can be for some folks craving. I think that where I see that most are in my PTSD patients. What's interesting with cannabis and PTSD, especially with sleep and night terrors, and PTSD can be anything from sexual abuse, active war, motor vehicle accidents. Part of the problem with PTSD is that the memory patterns get entrenched, and the nervous system can't let go of the painful memory. Part of what marijuana does is it helps the nervous system reprioritize the importance of the trauma. And I find that my vets especially do have pretty serious cravings for the marijuana when they are trying to get off of it for sleep. Most of them honestly prefer to continue to use it rather than to deal with that. But again, as I said, if you go out of state, it's illegal to take the marijuana with you. Can be a very big factor for a lot of people. And sometimes the mental cravings is something that does not go away for 4, 5, 6 weeks. So it can be a long-standing thing. I find that is more the case with social recreational users. I think that medical users tend not to associate the pleasurable aspects of it and have cravings from that. But marijuana does cause mental cravings, which means it's kind of like wanting popcorn at a movie theater. You have this idea that you want something. There's not necessarily a physical withdrawal where your bowels stop moving or something like that.
What are the advantages of having a prescription for medical marijuana now that there are places to get recreational marijuana?
Thank you. The main advantage, there are two major advantages. One is price and quality control. And marijuana is, in many ways, as it becomes more regulated, going to become more expensive. Patients have the legal ability to grow their own medicine. It should be no more expensive than $5 a gram, in my opinion, or else something is wrong. But if you grow your own, it is cheaper than growing your own tomatoes, for example. But where I see the biggest problem with recreational marijuana and now medical in the state of Washington, because it's trying to be moved behind the recreational, are pesticide use. There are I was in a panel once, and I said that the state of Washington approves over 200 chemicals for the use of marijuana, and I got slapped. No, they don't approve it, they allow it. Just about every single marijuana plant in the recreational market is dipped in a substance called floramite. Floramite, write that down, F-L-O-R-A-M-I-T-E. It kills spider mites, and when they bring the clones into these big 10,000, 50,000 square foot greenhouses, they don't want any spider mites because that can be very expensive to have to throw away that much of a crop. So they dip them in floramite. If you go to the Environmental Protection Agency, this is just one of 200 chemicals that the state has. The state does not approve them; the state allows them. If you go to the EPA website, the EPA says, well, this is for ornamental evergreens grown in greenhouses. So not only are they nowhere near people's homes, they're not even near people's mouths or lungs, so we don't need to study floramite for harm in humans. That's just one chemical. So I think that the benefit of a medical card is that it allows patients to have cheaper access and also to have some degree of control over what is sprayed on the plants, and there's just a huge recall in Oregon, about 30,000 edible products that have been sprayed with a certain kind of pesticide, and the governor of the state of Colorado just ordered a bunch of marijuana to be destroyed because they are using unauthorized or unapproved pesticides. I think that this is a huge problem, and that the legislators, and I went down to Olympia and I sat for an entire day to wait to talk, and they did not allow one physician testimony on this new law that they passed, and they called it the Patient Protection Act. And you guys are not being protected with the current laws in the state of Washington, largely because of pesticides. Almost all of the recreational marijuana is dipped in floramite, and they allow over 200 chemicals. And if you're a business person and you have a 10,000 square foot grow and your plants have problems, there is a financial incentive for you to keep those plants alive, and it is not illegal in the state of Washington. That's something I feel strongly about. I think that the safest and cheapest way is to grow your own, but that's not an option for everybody. I like the cooperative model as well. I also think that if you look, I won't comment on it. I won't comment on that. That's a little political, but follow the money.
Would you say a bit more about the difference between edible versus smoking?
Yes. And I will say inhalation versus smoking, because remember, you don't have to smoke to take it into your lungs. Every modality has advantages and disadvantages. The main advantages of inhalation are adequate dose titration, meaning the patient gives the patient a large degree of an ability to control the dose. For example, if you have a little too much with an inhalation, you just have to wait 30 minutes. The main downside of inhalation is it does not go through the digestive system, so the liver doesn't act on it, so it does not last very long, usually about 2 to 4 hours for the inhalation. That's where the main benefit of an edible comes in. Edible duration is usually 6 to 8 hours. It can be more if the dose is higher, so that for marijuana, for somebody who's having trouble sleeping through the entire night, a lot of the times an edible might be a greater benefit. However, edibles do tend to make people more stoned and are sometimes not a great daytime option. They're also not a good option if you've had too much, which sometimes can happen, especially with new folks. So if you've had too much of an edible, it can be an uncomfortable process for a number of hours versus an inhalation, where typically I just tell my patients, just look at your, if it's an inhalation, you just look at your watch and in 30 minutes you'll be fine. With an edible, you're looking at a longer ride, and I think if you talk to physicians in the emergency department, the vast majority of people who are coming in are freaked out because they think they're going to die because they had a big dose of an edible. And what they do in the emergency department is they sedate them, they watch them, and nobody has yet ever died, as I had said before, but it sure doesn't feel like you're not going to die. So that's one of the big disadvantages of an edible. And so please, folks, be very careful with your edible THC levels. Start at about 5 milligrams or less when you're beginning with those.
Thank you. My name is Judy. I'm from Edgewood. First of all, what kind of medical degree do you have? And second, have you used this yourself?
Both good questions. My medical degree is, I have a degree in, I'm a doctorate of naturopathic medicine. A lot of folks haven't heard of that. I trained and studied at Bastyr University here in Washington. We are trained to do primary care medicine. We prescribe drugs and medications, although luckily for me, I do pain, and the strongest prescription that I can write is for codeine, which is so good for me because I don't have to worry about folks shopping for opiates. It makes my life a lot easier. One of the things that we do as naturopaths is we spend a lot of time studying botanical and plant chemistry. The basis of modern pharmacology comes from plant chemistry, and I think that my criticism of my colleagues on the conventional side is that they don't get the idea that botanical drug, even by the FDA's classification, is in a different class. So I think that they're trying to fit the botanical drug into the model of the single molecule drug, and it just doesn't fit, largely because there are so many different types of marijuana. In terms of, do I use marijuana? Yes, absolutely I do. I am a big believer in topicals. I suffered something in 2003 called a Lisfranc injury to my right foot. They used to amputate that at the knee. Then this doc came along by the name of Lisfranc, and he came up with a surgical procedure where they just cut the front half of the foot off. I was immobilized and in a non-weight-bearing status for 4 months. When I got out was the big test of how much weight I could put on my leg, and I needed to be able to press 20 pounds on my right leg because I needed to not only build muscle mass but also bone density in that leg, and I could only press 7 pounds. The smoked marijuana or inhaled marijuana does not work for me for pain at all. In fact, I've had a couple strains actually make it worse, but the topical works fantastic for my foot. I really can't run anymore, but I can walk and I can do non-weight-bearing things, including maneuvering on a surfboard, and I can get low, and I'm 49 years old, going to be turning 50 here soon. I have a number of Ultimate Fighter patients who utilize the topical, and if you remember the Super Bowl between Seattle and Denver that they called, I think, the Marijuana Bowl or something like that, they actually asked the commissioner of the NFL, what do you think about medical marijuana? And he said he's all for it as long as it's got a legal status. I believe that a large number of our professional athletes are using the topicals as well, and the topicals are non-psychoactive, and they offer me a great deal of pain relief. I have patients who get pain relief from other methods that, for whatever reason, doesn't work for me. So thank you for that question.
I think we have one more question.
stoned to drive, or?
You're always too stoned to drive. That's one of the problems with the laws. This is a great question. Alcohol is a general nervous system suppressant. So this is an excellent question, and it's not a short answer. Currently, the DUI limit for marijuana is 5 nanograms per ml. Marijuana is not a universal depressant. In fact, some folks can be perfectly functioning at levels higher than 5 nanograms, and other folks can be impaired at levels less than 5 nanograms. Additionally, the same person can be an impaired driver at, say, 10 nanograms per level one day and be non-impaired at the same level on another day. So right now there is a case law, some poor gentleman who was a patient and who got pulled over versus the city of Kent. And what the argument, and this is going now to, I believe, it's been appealed and is going to one of the Supreme Courts of the state. The defense argument is that a patient has no way to tell when they have gone from legal behavior to illegal behavior. And so the general rule, and I actually make my patients now sign waivers saying that they're not going to drive, you might not be high from marijuana, and yet you could be impaired. So one way that you can work around that is utilizing strains that are very low in THC, and also just knowing that DUI is a science with alcohol. At 0.08 blood alcohol, everybody in this room is impaired. At 5 nanograms per ml of THC, not everybody is impaired. In fact, I would argue that most regular users are not impaired, yet all of them would be going to the same jail. And what's also interesting, if you get a marijuana DUI and you want to drive, you still have to blow into the alcohol tube. So I think that the case law is going to really be fiercely fought out, and I do not recommend that folks drive. It's not really one of the better things about it. But remember that opiate medication and other medications can impair driving. It can be days, depending on the patient. I don't recommend my patients to drive for six hours after inhalation and for about 12 hours after an edible. And even then, you're not necessarily safe if you're doing high THC. But if you're doing like a 16-to-1 ratio CBD to THC, and you're only getting about 2 or 3 milligrams of THC, you would definitely be okay. But remember, marijuana builds up in the system, and it is not a general depressant like alcohol. It behaves differently. So, great question. I'd just like to say thank you all for coming and listening. I know you have other events today. You can email me here. I'm pretty bad with email, but if you put the marijuana or cannabis in the thing, and also I blog at Cannabis Matrix, and you can also find Judy is going to be, and Rod are going to be posting this video on the group's site, and I'll also put a link to it on my site. Thank you all for coming. I really appreciate your questions and listening. It was really great to be here. Thank you.
Thank you so much. Thank you so much, Dr. Felice, and great that we have a few questions out there. But yeah, I will definitely link today's video. Rod was generous enough to bring his video camera and tape today's talk, and so we'll make that public to everybody, for those of you that came a little late as well, so you can get a little bit of that. So thank you, Dr. Felice. I know he has to run right now to go to Tri-Cities now to give another talk on the same topic. So very